Good afternoon. We're going to go ahead and get started at Department of Medicine Grand Rounds. Thanks for joining us both in person and online. We really appreciate that. My name is Ted Johnson. I'm the Division Director for General Medicine and Geriatrics. And for today's introduction, I'm introducing you to the William T. Branch Junior Fund for Innovations in Primary Care. So I do this both as Division Director, but also as a committee member, and our committee is chaired by Shelley Ann Fluker. So Dr. Branch is a recognized innovator and medical educator in primary care and in the disciplines of general internal medicine. He is recognized far and wide for this outstanding work. And the William T. Branch Junior Fund is a quasi-endowment that supports interchange and exchange with folks who are also opinion leaders and thought leaders, and our speaker today is no exception. And so our speaker will also, for Grand Rounds, will also be leading the keynote at the Learning to be a Better Teacher workshop. And I just want to say that in reading this book, I found about 10 pages about our speaker in the book. And so I'm super charged up to have you get to hear him, please.
Good afternoon, everyone. My name is Dave Schulman. I have the pleasure of serving as the chair of the Academy of Medical Educators for the Department of Medicine. It's my privilege this afternoon to introduce our speaker for today's Grand Rounds, Dr. Eric Holmboe. So Dr. Holmboe attended college at Franklin and Marshall, medical school thereafter at the University of Rochester, and then completed training between the Navy and Yale in internal medicine, served as chief resident in internal medicine at Yale thereafter, and then subsequently completed a Robert Wood Johnson Clinical Scholars year thereafter. He currently serves as the chief research, milestone development, and evaluation officer at the Accreditation Council for Graduate Medical Education. And in that role, he's been helpful to me as well as many other program directors around the country at improving the quality of evaluations that we provide to our learners. He's no slouch in the scholarship area either, having produced more than 250 peer-reviewed manuscripts, predominantly in the area of improving education and assessment of that education. He currently carries appointments in addition to his primary work at ACGME at Yale, the Uniformed Services University of Health Sciences, and at Northwestern Feinberg. As Ted said, tomorrow he'll be our keynote speaker at the Learning to Better Teachers conference, where he'll be talking about outcomes-based education and where we are and where we're going and where we've been. But today he's going to speak a little bit more about clinical skills in the area of progressive automation. Please give a warm welcome to Dr. Eric Holmboe.
Well, thank you very much for having me. It's really a treat to be here. I was here a few years back and always really admired the work here at Emory and in so many ways, particularly Bill's work. So Bill's one of my heroes. I'm a general internist, and so you can't not be a general internist and not admire what Bill Branch has done over the years. Particularly his textbook, a number of years ago, really was kind of the Bible for me. And so it's really a treat to be here. I will be perfectly honest, I am actually quite nervous about today because Bill being in the room and also being in front of you. But I hope this talk will at least be provocative a bit, maybe some food for thought. These are just my disclosures. So what I'd like to do is really talk about the context of clinical skills in what's being called the second machine age. This is a really interesting book that came out in 2015, and this is a quote from early in that. We are living in a time of astonishing progress with digital technologies. We're at an inflection point, a point where the curve of progress starts to bend a lot because of computers. We are entering the second machine age. So their argument is the second machine is really all around computers. Unlike the first machine age, which was really about the Industrial Revolution and creating these machines, computing is kind of the second machine age. And they say part of the reason this is happening is because the growth in digital capabilities continues to be exponential. Some of you may be familiar with Gordon Moore's law, where the ability around transistors and their speeds doubles every 2 years. We are reaching an inflection point there where that's beginning to slow down. And so now there's a lot of interest, for example, in quantum computing, where we're literally moving into transistors at the subatomic level. They also point out we're beginning to overcome what's called Moravoc's paradox, where decision algorithms have been relatively easy in many respects, but it turns out getting machines or robots to do motion and movement has been very hard. But even that's changing. Some of you may have seen some of the videos around a robot that can now run and jump over logs, or now can do a backflip. So that has actually been very important, because it's likely going to translate for us into things like artificial limbs and other things that'll have capabilities very similar to having your own appendage. In 1941, Isaac Asimov, who wrote the book called I, Robot, actually one of movies I really enjoy, kind of a science fiction fan, wrote these 3 laws of robotics. Said, 1, a robot may not injure a human being or through inaction allow a human being to come to harm. 2, a robot must obey the orders given to by human beings, except where such orders would conflict with the first law. And then finally, a robot must protect its own existence as long as such protection does not conflict with the first or second laws. For those of you who saw the movie, recognize that the central brain overcame that by recognizing that, well, humans were kind of a harm to themselves, and therefore robots had to intervene. Kind of a fascinating take on the 3 laws. But nonetheless, despite this somewhat dystopian future, robots are beginning to enter into healthcare. This is Pepper. Pepper is a robot that's being used in some of the hospitals in Belgium, and Pepper can actually recognize human emotion, which is kind of interesting. So the question is, how are robots going to affect our future? And so a lot of folks think that, okay, well, with all this artificial intelligence, we're just going to become obsolete. This is literally the cover from the PMJ back in 2018. But as they point out in the preface, machines that can learn and correct themselves already perform better than doctors at some tasks, says Jörg Goldhahn. But Vanessa Rampton and Jigan Spinas maintain that machines will never be able to replicate the interrelational quality of the therapeutic nature of the doctor-patient relationship. So this whole issues around this various debate as to what role will artificial intelligence actually play, and will it actually replace us as physicians? JAMA, by the way, has a website that now has all of the articles that it's written on machine learning. And so if you're interested, this is kind of a fun thing to take a look at to see where some of the progress is being made. This just came out this past week where, again, where artificial intelligence, machine learning has probably been most helpful is in imaging, particularly radiologic imaging, pathology, et cetera. And this is an article that found that an AI system was actually more accurate when only a single radiologist read a breast film, and was equally accurate when you had 2 radiologists read a film, the kind of member checking. And so I do think that down the road, AI is going to become part of our life. Well, some of you may remember all the hype around Watson. So back in 2011, Watson beat Ken Jennings, in the Jeopardy game, and everybody thought this is the future. And so IBM invested a lot of money into Watson, actually set up something called Watson Health, and they called it their moonshot. But it turns out that that hasn't actually gone real well. And so this is a quote from a recent article of all places, Forbes, where they said, looking beyond images, however, even today's best AI struggles to make sense of complex medical information. And encoding a human doctor's experience in software turns out to be a very tricky proposition. While the company IBM isn't giving up on its moonshot, its launch failures have shown technologists and physicians alike just how difficult it is to build an AI doctor. And so they had several projects. One was in oncology, where they would pull all this information with the belief that it would do a better job in diagnosing cancers and also being more accurate in recommending therapy. And so they worked with Sloan Kettering, they worked with MD Anderson, and that actually hasn't gone real well. MD Anderson actually has abandoned the project. They were working in leukemia after spending $62 million. Sloan Kettering is stuck with it in the belief that it'll still be helpful. What's particularly interesting is that Watson early on had part of its work just simply to supplement a physician and be kind of a diagnostic aid. And that was actually found to be pretty helpful. But because they didn't think it had a market, they abandoned the project. So they aren't continuing to use it at the moment, although there's still folks that are arguing they should come back. We will see where this goes, but I think that what seemed like, oh yeah, this would be great, we'll just take all this medical information, we'll pull it, and it'll be really easy, has turned out, no, there's a lot of nuance in caring for patients. Who knew? And so, AI and its algorithms just aren't quite up to that task. They might be at some point, but for the foreseeable future, humans are going to be pretty important. So in that context, let's talk about the healthcare journey of Charles. I know we like to talk about a patient, and so let's use Charles as kind of our case study for today. Charles is an 83-year-old PhD trained mechanical engineer, still working when he suffers an acute extensive large bowel infarction due to incarceration. He had a piece of bowel, unfortunately, near the cecum that got caught in both a scar and part of a small hernia, and he infarcted from the cecum up to the splenic flexure. Despite 2 operations, delirium, and a week-long ICU stay, Charles is successfully transferred to the medical ward under the care of rotating hospitalists for continued recovery, physical therapy, and therapy for swallowing dysfunction. Unfortunately, multiple medical misadventures ensue. He has a delayed diagnosis of hospital-acquired pneumonia, delayed diagnosis and treatment of pseudogout, which greatly hindered his physical therapy. He had a stage 3 sacral decubital ulcer, poor care coordination between the cardiologist, infectious disease, and multiple hospitalists, and repeated handoff errors. Despite all this and more, Charles is ultimately discharged to a rehab facility where he continues to receive, for unclear reasons, multiple salt tablets daily that leads to anasarca. Unnecessary trip back to the emergency room for a diagnostic error, a second case of pneumonia due to a feeding error, and multiple sessions of physical therapy are missed. After 93 days, Charles loses ground and is subsequently discharged from rehab center to home under hospice care. On discharge, he describes his rehab experience to the social worker as being, quote, treated like a thing, unquote. He dies 8 days after discharge. What I'd like you to do is find a friend for just a couple minutes and reflect. Have you ever experienced poor or unsafe care with a family member or yourself? Have you ever witnessed poor or unsafe care as a healthcare professional? And what is the role of the medical education system in improving care for patients like Charles, particularly in the employment of clinical skills? All right, so spend about 3 minutes just having a brief conversation reflecting on this particular patient. All right, let's go ahead and regroup. We will come back to Charles at the end. So let's take a look at healthcare outcomes and the role of clinical skills, even in this era of honestly accelerating technology, which again, I don't want to give you the impression I'm anti-technology here, but like anything, you have to know how to use it properly. So it turns out that clinical skills are still really important. This is a nice study from Mark Graber that took a look at what happened to patients when they had an adverse event. This was 74 patients who experienced an adverse event, and then they did kind of a root cause analysis to figure out what were the errors that led to that adverse event. And it turns out it wasn't really a simple, just single thing. That, as you can see from the slide, on average, there were roughly 6 system and cognitive errors per adverse event. What was interesting, however, in totality, despite the system obviously being very important, in totality, there were more cognitive errors than there were system errors. And a number of them were due to faulty data gathering. But in this case, again, these are practicing physicians in a hospital. 264 of the cognitive errors were due to faulty synthesis. In other words, clinical reasoning. They had the right information in front of them, but they didn't make proper sense of it. And so again, this clinical reasoning skill is very important, and not something that a computer is going to be, well positioned to easily do at this point. This is a more recent study from Hardeep Singh, who's done some wonderful work in Texas. They did a very interesting study. This wasn't a training clinic, where they pulled charts of any patient that was unexpectedly seen 14 days after an index visit from the clinic. In other words, they weren't expected to need to be seen within that time period. So any patient that came back to the clinic, was seen in the emergency department, got admitted, were reviewed. And you can see that there are a lot of what he called process breakdowns between the practitioner and the patient. And many times it related to, guess what? History and physical exam, right? So even physical exam in this case was turned out to be really important. And when they've looked at this data in other studies, this extrapolates to as many as 50,000 misdiagnoses in primary care each year in the United States. Again, showing that both the kind of inputs, the data collection, history, physical, good communication skills, and the output, the clinical reasoning, are really important. More recently, the National Academy of Medicine published this report. And what was interesting about this, the reason they took it on is that they look at diagnostic error as a patient safety problem. And the data, again, is pretty sobering. The one at the bottom is the one I highlighted, that every American, that's now roughly 330 million people, will experience at least one diagnostic error in their lifetime. The good news is many of them are not consequential, but we know from many studies now that many will be. And so again, this kind of making a proper diagnosis, what does it take to do that? And clinical reasoning matter, and it matters a lot. This got a lot of attention. This was published in BMA Quality and Safety. This is Makary and Daniel from Johns Hopkins, where they took a look at all the systematic reviews that had been done. And this is now medical error, which includes both diagnostic and therapeutic error. And they concluded, based on their review of all the literature, that medical error is now the 3rd leading cause of death in the United States. Obviously, this is quite controversial. And from my standpoint, I'm not sure I really care if it's 3rd or 10, it's just too many. And they point out that a lot of this has to do with errors in the clinical skills side. So if that doesn't get your attention, are clinical skills important? Let's explore some other data. Well, these are what I call the key basic clinical skills, and you could certainly add others, but these all still really matter. And the reason I put basics in italic is they're not so basic. To do these well really takes a level of expertise and mastery. And when you have that, we know that you can get to better outcomes. So medical interviewing, physical exams, informed decision-making counseling is really important for patients. Procedural skills, despite all the technology now, we're still seeing many errors in procedural skills. Interpersonal skills, as I said, clinical reasoning and judgment, and reflective practice, being able to learn when things don't go well so that you continually get better, I see as a clinical skill. This is the definition for clinical reasoning, and this is also a field where there's been a fair amount of research over the last decade that I think is expanding our understanding of this process. The definition here is it's a process that operates toward the purpose of arriving at a diagnosis, treatment, and/or management plan, as well as striving for improved patient outcomes and well-being. And so this really covers the whole spectrum. The first part of that is what's called the diagnostic process. This is from a recent publication from the Society to Improve Diagnosis in Medicine. This group is really doing some wonderful work. And you can see that the diagnostic process is, guess what? It's kind of complex. The patient comes in with a health problem, they engage the healthcare system, which we know in the United States is not always easy. And then they enter this kind of cycle of information gathering, interpretation, and a working diagnosis. And then based on the inputs, which are clinical history and interview, physical exam, plus or minus diagnostic testing and consultation, you're constantly refining that working diagnosis. And then once you come to a decision, that needs to be communicated, the treatment needs to be planned with the patients, and you hope that that leads to both better patient systems outcome. A systems outcome, for example, is they don't show up again in 14 days, that they get the proper treatment, and they don't need to be seen again because of a misdiagnosis. So this is a complex process. We also now know in making a diagnosis that it's not just about what you carry on the hard drive and that one-on-one encounter. This is a group of work called situated cognition. Steve Durning and others have been working in this area, but it shows that there are multiple factors that can affect how well that diagnostic process actually turns out. The physician factors are, what is their level of expertise? How well are they self-regulated? In other words, are they intrinsically motivated? Do they set goals? But also, what is their current state of well-being? Are they burned out? What is their current level of fatigue or alertness? We know that can affect their performance. And then patient factors affect the ability to make a proper diagnosis, as well as practice factors, appointment time, how much chaos is going on, etc. And so all these things interact to produce a clinical outcome, but also affect the diagnostic process. This is a nice article, or chapter rather, from Alice Frona and Larry Gruppen, published some years ago, but I think it's still very helpful. It kind of shows that diagnostic process and shows all these interactions that you have to keep moving back with these bidirectional arrows. It also highlights that you can't have an empty hard drive. Some prior knowledge is important, but that the history of present illness and physical exams still matter. And those combined should lead to what's called a problem representation. In other words, what do I think is going on? What's the differential diagnosis? And then that should be evaluated. There should be a period where somebody steps back and reflects and says, do I have this right? And if I don't, do I need more information? That information might be going back to the bedside and doing more history and physical, or it might be looking something up because I'm not quite sure, or it might be talking to another colleague, etc. And again, context, as I showed you with the situated cognition model, affects all this. And finally, you move to action. And we've learned over the years that within this process, there can be lots of things that get us into trouble that lead to error. One is just simply not having enough knowledge, deficiencies on the hard drive. Poor clinical skills, as I've showed you, can lead to error. And then synthesis error, which is very common in the Graver study, is another area that we need, I think, to really continue to work on. And then finally, there's a classic phenomenon, what's called premature closure, where you think you recognize a pattern and you prematurely close on that without taking a step back. It's interesting that you showed the book, Every Patient Tells a Story. It's from Lisa Sanders. One of the stories is actually, I think, worth highlighting, which was a premature closure problem. A patient was being readmitted to my service for the second time with an asthma exacerbation. I've been seen multiple times in the ER, did get a little bit better on steroids, but as you took the patient's history, there was nothing in it for a 52-year-old woman that screamed asthma. She never had asthma, she wasn't having any occupational exposures, and it turns out that she was basically in chronic heart failure due to a ruptured chordate tendon of her mitral valve. So she just had wide open MR. And nobody had heard the murmur. And you worried, did they listen well enough? But in the end, that patient needed a valve replacement. But that's a classic example where the history was critical. You could say like, well, you could get an echo and you would have picked it up, but you have to know to get the echo. And that's where the history becomes so important. Well, it turns out that that history, as I said, is important. There's evidence behind it. There's been several studies that have found that 80% of the time, if you do a really good job taking a history, you can make an accurate diagnosis. How many people have heard that adage, 80% of the time? How many people think your faculty just made it up, right? 80-20 rule? Well, no, it comes from several studies. The first was done in the mid-70s in the UK. That was kind of the pre-imaging era. So a gentleman by the name of Peterson in Utah in the early 90s repeated it. You know, we now had more technology, and guess what? Found the same thing. In fact, in both those studies, laboratory testing was only helpful about 10% of the time. And so faulty data gathering is one of the common reasons for diagnostic error, and we know it's associated with increased mortality. We also know that patient-centered care matters. Excuse me, I'm getting over a cold. That these things are not just nice to have. They're not just icing on the cake. That when we use patient-centered care, all of these things can happen. There's multiple studies, as you can see from the references, that show that these are the kind of outcomes you get when patients work with health professionals who have really good communication skills, right? So if you have really good communication skills, take a proper history, but also on the informed decision-making side, you're gonna do better. And this is just a really nice graphic from Wendy Levinson, who's been a leader in this field over the years. I think, Bill, you've certainly known Wendy through SDIM, where she showed that this causal chain is real, right? There is a logical sequence. There is a cause and effect that if you get down the road, you will get better health outcomes. So preparing people in these skills, again, they're not just nice to have, they're really essential for better outcomes. However, having said that, there are some things that we do need to acknowledge. You obviously cannot function as a health professional with an empty hard drive, but there is simply way too much information to carry all that is needed in your head. Anybody recognize this x-ray? Homer Simpson. Yeah, I'm always really depressed that when I go overseas and I mention Homer Simpson, everybody recognizes who Homer Simpson is, right? Maybe it's our greatest export from the US, I don't know, but I do find it kind of interesting. This is a really other nice study from Delfoya kind of highlighting the point. So what they did is that they did a systematic review of kind of studies that have looked at how often does a clinical question arise in the course of providing care. And these are among practicing physicians. And what they found across these studies that on average, a practicing clinician will encounter a clinical question for 1 of every 2 patients they see. That might be something minor like the dose of a medication. But many times it's actually like, I'm not quite sure what the diagnosis is, or could I be missing something? And so this is really important to recognize that no matter how smart you are, you're still going to run into stuff you don't know. And it happens pretty frequently. What was a little bit sobering about this study is that even though these questions came up, physicians were only able to pursue about 51% of them. And then of the 51% they pursued, they were able to find answers for about 3/4 of those. So you can see the voltage drop here that by the time you get down to what was actually answered, it's only about 1/3. So this is where I think clinical decision support, where you have better access to information that's efficient at the point of care is going to be important. Because the reality is no amount of testing is going to fix this. It just isn't. We can keep giving multiple choice tests. It's fine as kind of a foundational assessment of your knowledge, but this is just reality in practice. And I really like this study from 2011, William Stead and colleagues, just pointing out that, again, the amount of information is becoming available is just exploding. And it turns out that humans can only hold about 5 sets of fact in their head at any given point in time. And there's just going to be times where you're having a patient where it exceeds that capability. And so you're going to have to essentially use clinical decision support to help you. It's just reality. So the question is, how do we do this well? And particularly with genetics, where actually, by the way, Watson has had some success. As you think about all the stuff that's happening in oncology. Any oncologists in the room? Yep, one in the back. So you live this. But one of the things they found is that using Watson genetics, about 1/3 of the time identified a treatment for a mutation that the physician had not thought of. And so that's an example where, again, as a clinical decision support could be helpful. I also believe we need to rethink our work. This is, again, from the Society of Improving Diagnosis Medicine, who've come up, by the way, with a set of competencies for clinical reasoning. And there is a set of individual competencies. What I really like about this work is there's a set of competencies for teams, and there's a set of competencies for systems. And the data is growing that group process actually leads to a reduction in diagnostic error. I think that's part of the beauty of being in a teaching program, that when you round, you're bringing collective expertise, collective competence into that conversation. There's no question that helps. But for many of the folks, when they go into practice, they no longer have easy access to that. And so this concept of a diagnostic team and leveraging the expertise, I think, is going to be important. We're going to need to rethink how we approach diagnosis. It's not just a solo act. And as I said, we're going to need to use clinical decision support. So a lot of people argue that it's not so much about artificial intelligence taking over, like Sonny the robot or Pepper. It's more about augmented intelligence, that we have these clinical decision support systems that help us do our job better. And there are some useful apps. And so what I call kind of a poor person's Watson is this one. Anybody ever use Isabel? What do you think of it? Yeah, I really like it. Do you know the story behind Isabel? So it's a really interesting story. Isabel is the name of the daughter of a gentleman by the name of Jason Maud. Isabel had the chicken pox. Now, this is back in the 90s, and developed necrotizing fasciitis, and it was missed. And so had been to the clinic several times. The diagnosis wasn't picked up. And of course, Isabel got really, really, really sick. Ended up in the ICU for several months, but survived. And so Jason, who interestingly was a venture capitalist, wasn't the least bit interested in suing. He said, like, how can we fix this problem? How did this get mixed? Could there have been something to help them? And so he developed this starting around 2000, 2001. And so it's had several iterations. Like you, I really liked it when I was doing volunteer care in a local clinic. Since I wasn't doing a lot of care on a regular basis, I ran all my patients through this. It was just helpful for me, who might have, things might have changed and I didn't know it, to make sure that I wasn't missing anything. And so I liked it. But this is an example, and ironically, this is what Watson abandoned, was something like this, which I think is kind of ironic. But this is a very useful tool, not expensive. And so it's one of the things we can continue to use on a more regular basis. So it's great to hear somebody's actually using it. Having said that, faculty still really matter. And I think that's the important thing we don't want to lose sight of. This is still one of my favorite studies from Brendan Riley. Although it's a bit dated, I think it's actually held up pretty well. What Brendan did at Cook County Hospital is that he took a look at 100 consecutive admissions, and he was interested to see which physical diagnosis findings had been missed by the residents and or the ED that changed the patient's diagnosis or management. If it was an incidental finding, they weren't interested in counting it. All right, now this is physical diagnosis findings, right? Right, not just history, which we think, well, physical diagnosis, maybe it's become antiquated. So I'm going to do it through a show of hands. How many people think he found 10 physical exam findings that change patient management or diagnosis? How many think 15? 20? 25? There's 26. All right. That's 1 in every 4 admissions to the hospital. Again, one of them was an example of a woman who had a temporary dialysis catheter in place, comes in with a fever. The diagnosis is line infection. When the faculty went to see the patient, it turns out that the patient's got a wide open AI murmur due to a 2-centimeter vegetation on the aortic valve, right? And so again, the kind of comment was like, well, you picked it up on echo. Yeah, I'd sure like to pick it up before that vegetation embolizes and causes a stroke. And that patient actually needed urgent surgery. And that's an example where, again, physical diagnosis and having that part of your differential, yeah, the most common thing is a line infection, but what else could it be is really important. And so I don't know how many of you are familiar with this. This is Abraham Verghese's site, but it's really, he calls it the Stanford Medicine 25. These are still physical exam maneuvers that are important and still have value. Not everything does. I'm curious, how many people still use Tunnel and Phelan sign for carpal tunnel? I got bad news for you. Not better than chance. Just the way it goes, right? Not everything works. There's also a wonderful book by Steve McGee called Evidence-Based Physical Diagnosis. So if you haven't seen that, that's another one I'd strongly recommend. It's really well done. We also know from several interesting studies, and we did one that ultimately wasn't published, but there's studies that have actually had faculty see a patient after a resident kind of in parallel. And these 2 studies, the way they were done is that the resident presented to a preceptor, and then the preceptor was asked to kind of put their nickel down. What do you think's going on based on the presentation? And then the patient in alternating order was seen by another faculty attending. They looked to see if there was agreement between what the preceptor thought based on the presentation from the resident and what the other faculty had found. And you can see there was major discordance in 30% of the cases. In Mark Guinness's study, some of that discordance was actually pretty serious. That put the patient at risk. We did a study at Yale where we literally put a microphone on the resident and the patient. And we followed the patient through the whole clinic. And then we listened to what happened in the room and what was said to the preceptor. And we found very much the same thing. About 1/3 of the time, what was said to the preceptor did not match what had happened in the room. Now, let me be clear. It wasn't the residents being malicious or trying to play games. But a lot of times, it was basically poor clinical skills that was getting in the way. One common thing we found that we weren't aware was happening, that residents would often pick up the chart before going into the room, kind of scan it, and then go in and take a history, but that history would often be very close-ended. Just a whole series of questions, close-ended questions. You're not having chest pain right now, right? You're having this. And then they come out and they would create a story. And that story would be an amalgam of this kind of close-ended history, and they'd impute what they'd found in the chart and present it as if it had been a history of physical illness. And in fact, that's not what had happened in the room. And as you can imagine, the faculty appropriately took that as the history of present illness and made judgments based on that. Again, it's just another example of why clinical skills are so important and why we have to help our residents who I see are with us here today get really good at this. And so, for the faculty, the reflection for you is, what has been your own experience? Have you ever walked into a room and you were pretty sure you weren't in the right room, right? And again, that's no reflection on the residents. It's just that we have to take these skills very seriously. And in order to teach them well, guess what? You got to observe them. You just do. And we can talk more about that, particularly tomorrow. However, there's another elephant in the room, and this is work that I've done with Jen Kogan and Lisa Conforti. Many of our own clinical skills are deficient. And I think we just have to be honest about that we know from multiple studies that some of us as faculty don't have the best history taking or physical exam skills. Maybe we weren't taught how to do shared decision-making well, et cetera. The example I often use is some years ago, I was asked by a resident to come watch him do a thyroid exam. My first reaction was, awesome, they've asked me to come watch them. And then I had terror as I froze my place, like, wait a minute, thyroid. It's in the neck. And if they put their fingers on either side and have them swallow water, that's a 9, right? Because I wasn't good at it. I just had to be honest about that. And so we learned together. I grabbed Lyle Myers, who was the endocrinologist, and said, I'm not really good at this. Let's learn together. I just don't feel comfortable doing it. And part of this, we as faculty just have to own that and get comfortable, no matter what the skill may be. And just to highlight that, this is a study we did about 10 years ago. It was really focused on helping faculty improve the direct observation skills. But what we did is we had them in the morning undergo an 8-station standardized patient assessment. Of their own skills, the things that they were going to watch on videotape and live that we scripted in the afternoon. We stripped out all the stuff that wasn't a key feature because faculty don't work like a checklist. And so we really focused on key features. These were 44 faculty. These are general internists who love what they do, whose average years of experience teaching was 12, okay? And this was their performance on that standardized patient exam. When we met with them at the end of the day to debrief for the credit, they all had wonderful reflections. They said, you asked me to do certain things today that I'm not sure I'm very good at, that I was never formally trained how to do. For example, one station was breaking bad news. Most of them had never heard of spikes, even as a framework, let alone gotten any training in it. And so they themselves were beginning to reflect on what this meant for them. When we actually had them rate the videotapes and the 2 live encounters, the only thing that correlated with the ratings on the mini clinical evaluation exercise was their performance on the standardized patient. Age, experience, role, et cetera, had no correlation with gender. It was just how well they did. And those who did better on this were more accurate in their assessments of the videos and the live encounters. So I think part of it is we need to invest on ourselves to continually get better at this because it does affect the quality of the feedback and coaching that we can give our trainees. A follow-on study that we did was to see whether or not this kind of training could become a twofer, having recognized that some faculty were really challenged in some of these skills because they hadn't been properly trained. We built that in as part of the process. And what we found in our follow-on studies that, yeah, they can not only take this back and they felt more comfortable, more efficacious in doing direct observation and feedback and felt more likely to do it because they now felt they had efficacy, but they said that they had translated some of that training into their own clinical practice. And it said it actually helped them get better. One of my favorite stories was a faculty who had really never been trained how to do agenda setting in the clinic and was always perpetually running late. And when he learned that skill, guess what happened? He had far fewer days where he's running late. He said it just changed his life because it reduced the stress for him. But he had never been taught how to set an agenda with a patient in a clinic visit. And the minute he picked that up, it actually helped him in his own practice as well as helping his learners. So I think we have to think about faculty development as a twofer. So here's some concluding thoughts, and I'd love to open it up for conversation. So hopefully I've convinced you that history taking, physical exam is still important things that we need to do. Computers can't do that. There's too much nuance. There's too much judgment. You can see how complex that diagnostic process is, that we're still going to need humans for the foreseeable future. I think that's a good thing. This is also an article from the Harvard Business Review from a year ago that points out that these are going to be competencies that will be more important in an AI world. Communication, especially interpersonal. there's been a lot of work saying that the sense making is going to be critically important, that even for radiologists and pathologists and others whose imaging will initially be interpreted by a machine, that their ability to make sense of that in conjunction with all the patient information is critical. And that's actually where Watson has fallen down, that you need to pull in the context of what's happening to the patient in addition to just an interpretation of the image. And humans are still critically important for that. So in many respects, our radiologists and our pathologists are becoming more and more information specialists, right? And they need to be able to also help us make sense of those images as we care for patients as internists. That's really important. Emotional intelligence, critically important, managing context, and teaching. Again, is not something machines likely to be able to do well. We know from a lot of the teaching science that relationships matter a lot with regard to the effectiveness of the teaching. And so machines don't do that very well. I think Pepper's great that she can recognize emotions, but she's probably not going to be great in teaching complex stuff. That's where all of you are going to continue to be important. Back to Charles. Charles is my dad. It was a very interesting experience, one that was pretty sobering for me. I know a little bit about the system, and it was really remarkable to watch this whole thing unfold. And I just want to be clear that of all the folks that took care of my dad, I don't think any one of them was malicious and didn't want to do the best for him. But it was pretty clear that in addition to a number of system deficiencies, a number of the physicians were struggling with key clinical skills that really would have helped them. Myself, my wife, my sister and brother, we were the care coordinators. And if we hadn't been there each day, I wonder, if that, how it would have gone. It was really difficult. Ultimately, he just couldn't overcome. But in many respects, I think he suffered from something I call iatrogenic allostasis, that the repeated errors just took away whatever reserve he had left. And so it was really a mirror to self. And I think it also highlights how important the work it is that you do. Because I said earlier, we know that the quality of training and how well people prepare does go with them. What happens in Vegas does not stay in Vegas. The skills you acquire here, and now I'm speaking to the residents, I cannot overemphasize how important it is to you to get as good as you possibly can, because those skills will go with you. They will be important. They're a critically important foundation. Talk to more about the developmental piece of this, but don't be afraid to ask for assessment. I know culturally that's tough in medicine, but the goal is expertise. We know from research that without good observation, coaching, and feedback, it's very tough to get there. And so seek it out. Don't be afraid to ask for it. Work with your faculty to co-produce your assessment to help you get better. And I would argue that most of what happened to my dad would not have been fixed by AI. Yes, there were certain things around the system and the computer system that could have helped, but a lot of what happened with him were clinical skills and interrelational, right? The interpersonal and interprofessional teamwork. And so those skills really matter. Those other competencies that we struggle with, yeah, they matter a lot. It's not that medical knowledge and patient care are important, but so are those other communication skills and teamwork. They matter too. So in summary, patients and families have to remain at the center of what we do. AI, whether artificial or augmented, will continue to advance, and it should. And we continue to need how to use it well. And then finally, clinical skills will continue to be a vital part of high quality, safe care for patients and families. I think that's good news for us. I think that's what excites us about being physicians. And like I said, the good news is for us, it still matters a lot. So I'm going to stop there and open it up for questions. I'd love to get your reactions and thoughts about what you just heard.
So Eric, that was great. Thank you very much. We'll open it up for questions. I have one. You didn't mention the electronic medical record, which is our the bane of our existence sometimes, and how that interface can be enhanced by AI. Google Glass was on the stage a few years ago, but hasn't moved forward. Can you kind of comment on the electronic medical record and how we can use that as a more effective tool?
Yeah, no, I struggled as to whether how much to include about the EMR or not today. I think, as all of you know, part of the major problem with the EMRs is that when the systems were originally designed, they were designed as transactional tools. They weren't really designed to provide support for the clinical interaction. And so a lot of these systems, and now it's mostly Epic and Cerner, the market's kind of sorted out, are having to be retrofitted with that ability. I think they're finally getting the message. We've actually talked with Epic. not only from that standpoint, but also how can they be more supportive of the educational enterprise around data. I think that there is some work afoot to integrate better these clinical decision support tools and make them more easily accessible so you don't have to go out. There's some talk around that. I think that'll be helpful. I also think there needs to be an easier way to mine the data, and that still isn't easy to do. There are some systems that are doing that better. Interestingly, Kaiser's a good example where I think they've done a pretty good job mining their data and feeding it back to physicians. But they've been doing it for a long time, so they have more support. Mayo's done some interesting work where they have built into their EMR the opportunity for ongoing education, so it actually recognizes an ICD code, and then it pushes out a clinical question and update to you. So you can learn about that and make sure that you're keeping up to date. So that's kind of cool. It's kind of a push technology. With regard to things like Google Glass, I think there's still a lot of work on how to translate that type of information into useful feedback. We do know from a lot of work in surgical and procedural simulation that if you can capture the motions well, it actually tells you kind of where they are in their development. So it's interesting to look at the movement curves. The experts in, for example, early learners are very different. And so they're beginning to take a look at that. What's interesting, even video, I don't know if you've seen Berkmeyer's work, but they actually just simply videotape surgeons doing gastric bypass surgery for weight reduction, and just simply putting up the videos on a public platform, they were able to judge who was doing a good job and who wasn't. So there's actually a company now called CStats. It calls for crowdsourcing assessment of technical skills. And what they have found is you can just simply put it up and anybody can view it, and it's just as accurate in aggregate as if you take an expert. So I think we're going to see more of that, where there'll be more real-time feedback using some of these technological tools that can be built into the EMR. Then I hope things like Isabel become more accessible within the EMR. I know that Jason has talked. There hasn't been a receptor site there, but ultimately that just has to be all enfolded and not all these bits and pieces that are kind of glommed on.
The question is keeping the conclusions in mind, how would you change how things are evaluated?
Yeah, I think we're in the middle of a kind of transition. And again, full disclosure, I worked for a certification board for 9 years, but I think that the kind of over-reliance on kind of high-stakes testing and medical knowledge from the last century is going to need to shift. Nothing personal toward the test makers, but I think we've learned just looking at, for example, all the data on diagnostic error, that if the tests are working so well, why would we see that data? So I think we got to do a lot more work-based assessment, which means kind of in the workspace, seeing patients, what we call in vivo. Understanding, however, it's much messier. It's a much younger science, and we have a lot of work to do. And as you can see, if we're not helping faculty, we're still not going to get the kind of data we need. So I think that's one. The others, I think we got to empower residents to do more with their own assessment. This is where something called co-production comes into play. It's kind of a new approach that's finding its way into chronic care, but I think it has major impact for education. If you're interested, Bob Englander just published an article a week ago. It's now available in Academic Medicine. So I think that's got to change as well. And we got to make it safe for residents not to be afraid to ask. I mean, there's all things we can get better at. I'm curious for the residents, how many of you have read Atul Gawande's Personal Best? Yeah, I would strongly recommend you all read that. It's a great example of somebody who's very accomplished, who wasn't getting better, and actually had somebody come in to watch him operate, one of his former mentors, and recognized there were things that he could still do better, even as an accomplished endocrine surgeon at Harvard. I think that's the mindset we got to start to build among all of us. Yep, please. And then I think Bill, you had a question.
Couple of comments. One, I think when we round in the hospital and we walk in and the consultants are in the room, often it's like the two teams are, oh, excuse me, we were here. And it's, yeah. I've always found it good to ask the specialist, can you show us the pearls of what you do from a history and exam, you know, with this patient? So that's one comment. I work in the field of chronic congestive heart failure. The patients I see who are volume overloaded do not have edema, they don't have RALs, they don't have all the things that the medical students get taught about. But the individual patient or their family member will say, we know that he's retaining fluid right now because when he does, he has trouble tying his shoes. He gets short of breath when he does that. So some of this things around data and being patient specific is probably where the computers fall down, in that individual patients have their phenotype or whatever of how they express a disease, and it's very specific to them. And in order to do that, you have to know them, you have to listen to them, you have to,
Right.
So just your comments around that, or studies that are being done around what is truly patient-centered, specific history taking and physical exam.
Yeah, I think you gave a wonderful example of what patient-centeredness looks like. And in a co-production mindset, the patient is also an expert. So what you described is that patient, that family knows what the signs and symptoms are that are specific to that patient. And you're absolutely right. In the studies with Watson, what they found was Watson couldn't pick that up, right? It was so algorithmic that it couldn't deal with that nuance. So if something like that showed up on the chart, Watson didn't know what to do with it, but you would, because you have that relationship, you know that nuance. And it really gets to the point that we have to be serious when patients tell us stuff that, you know, they know what they're talking about. That's how they're experiencing their illness, and that's how it shows up. We can't just go with the classic findings. And that's something where I think, you know, you as an educator is so important to help your learners understand that yeah, not everybody going to show up as a textbook case. You know, there's the nuance, and that's where expertise comes in, recognizing all the different presentations, building this kind of illness scripts and what it means, and listening to the patient. There's a lot of nice work, by the way, in co-production that you, particularly working in a chronic disease area, might find helpful, about how not only can patients be an important team player in diagnosis. And by the way, the Society to Improve Diagnosis in Medicine as a whole patient group helping with them, and they consider them part of the diagnostic team. But also even in therapeutic management, co-production has been found to be very helpful. Best example, cystic fibrosis. Who's the most important health professional for children with cystic fibrosis? It's the parent, right? The goal is to keep them out of the hospital. In Jönköping, Sweden, they have now set up a dialysis clinic where 2/3 of dialysis are run by the patient. They hook themselves up to the machine, they run the dialysis, and they come in when it's convenient for them. The nurse serves as a consultant if they need help. What do you think happened to outcomes? They got better, right? So we have to rethink the role of the patient as their partner. And that's what co-production is all about. How do we co-execute, co-plan with them? And if that's the way they show up and they know that you take it seriously, I think sharing that with your learners would be incredibly valuable. Bill.
Yeah, well, first of all, Eric, let me thank you so much for coming and giving this talk, which is really in line with the passion that I have had through my career for looking at the clinical encounter and the clinical teaching. And you dissected it in wonderful and critical detail. I just want to throw out a thought and see what you think of this. That another factor to consider, you know, in terms of how we, where we run into problems, is our unconscious biases.
Yep.
An example of that is the concept of clinical inertia,
right,
that Larry Phillips and I described, where it is often the case that a physician will see that there is a problem, but rather than doing the difficult part of actually dealing with the problem right away, will just put off dealing with it until, you know, another time. Why don't you come back? Let's see if things get better and so forth. And I think there are other unconscious biases of the same type. Finding thinking a patient has a benign diagnosis because it's a lot easier to deal with that than a more difficult diagnosis, right, and things of that nature.
Yeah, the scary thing, there's over 100 biases that have been recognized. There has been work, there's actually been some studies trying to, by teaching what they call bias reduction strategies, that would improve things. So far, the results are really mixed. So simply telling people not to do it, so to speak, doesn't work. So it's probably more important to raise awareness and to give people a systematic approach. So for example, if you find yourself prematurely closing, like, oh yeah, this is what it is, it's that evaluation step where you reflect and say, what else could it be? This is where, like, Isabel becomes helpful. Should I just check? Take the 30 seconds to look that up. That's a skill that we can teach, but there's just a boatload of them. And so we really have to help folks. And you've mentioned several of them. Clinical inertia is very common, as you know, particularly in management of hypertension and other things. And again, it's getting people to recognize it. One of my favorite stories, when we ran a quality and safety curriculum at Yale, I would have the residents audit their chart. And then I would meet with them Friday to have them reflect on what they learned about themselves, what they learned about the system, what would they like to change. And one of our future chief residents walks in and says, like, yeah, you know, what's really interesting, I found that I keep putting things off. So she brilliantly described clinical inertia, and part of the reason was patients are complex with multiple issues, and she would say things like, well, you know what, I'll get that flu shot next time, or I'll worry about that preventive care next time. Like, yeah, the blood pressure's not too bad, I got all this other stuff. And what she found was that 4, 5, 6 visits would go by and none of it had been addressed. And so so for her, that was the aha moment in doing the audit, recognize she was engaging that pattern. So there's an exercise you could have your residents do. Is that something that they're actually doing? They could look for those kind of signs that they might be engaging in clinical inertia, is just one example.
Thank you. That's
Sure.
a great talk.
We really appreciate you coming.
Thanks for having me. Yeah, thank you.